Hello, and welcome to this module, which we've prepared for the Center for Advanced Studies in Child Welfare. The title of the module is Addiction and Child Welfare. My name is Amy Krentzman.
And I'm Goodenough.
And what we're going to cover in this module is what is addiction, what is recovery, and addiction and child welfare. First of all, before even jumping into this topic, we just want to say a heartfelt thank you to you for all the work you do with children and families. We appreciate how hard your work is and the challenges you face, and we really appreciate what you're doing on behalf of these people and these families. And that's forefront in our minds as we put together these slides to help you learn more about addiction so that it helps support you in the work that you do. Just to introduce each of us, my name is Amy Krentzman. I'm an assistant professor of social work at the University of Minnesota. I do research on addiction recovery, so my research areas cover spirituality in recovery, gratitude, forgiveness, 12-step programs, sober living houses, and currently doing a study on the nature of recovery in rural communities. I also teach the addiction course here at the School of Social Work.
And I'm Goodenough, and I'm a PhD student and community faculty member and research assistant here at the University of Minnesota. I'm also a principal consultant working with a consulting agency in the Twin Cities. I do research with Amy Krentzman in many of her areas of addiction and child welfare and that sort of thing, but I also teach courses and do consulting in macro practice social work, so nonprofit leadership and management, strategic planning, evaluation, fundraising, those sorts of things.
Our agenda for this module includes the following: what is addiction,
The conversation about addiction and child welfare,
the brain science of addiction,
the prevalence of substance use on child welfare involved families, as well as the impact on families and the child welfare system.
and also what is recovery. And we'll end with some takeaway points, like our favorite messages from this content. The topics in blue are general, and the topics in burgundy are specifically relevant to child welfare. So we'll get started now with our first topic, which is what is addiction. The first thing I want to emphasize is that addiction is not a question of morality, character, or personality. It's not a question of good or bad. It's a question of ill health, hopefully transitioning into good health. Substance use disorders are medical conditions. They are chronic illnesses with clinically significant impairments in health, social functioning, and the voluntary control over addictive behavior. And this has now long been established that addiction is a health issue. One thing that can be helpful in understanding addiction is understanding the symptoms of addiction, so you have a sense of when it's present or when it's absent, which can be kind of confusing to tease out. We assume you are familiar with the DSM, the Diagnostic and Statistical Manual of Mental Disorders, and the DSM-5 criteria for alcohol use disorder. We're going to use alcohol use disorder as a representation of other addictions. But the DSM-5 criteria are 11 different criteria, and they're in tiny text here on this slide for a purpose. We're not going to go over them one by one, but I'm going to sweep through all 11 in terms of 4 themes that they cluster around. So the themes within the 11 criteria are as follows: the theme of physiological dependence, the theme that drinking causes trouble, the theme that drinking interferes with other aspects of life, and the phenomenon of loss of control over drinking. And if their relationship with drinking exhibits these types of situations, then they're going to be building a symptom picture that could lead to a diagnosis of an alcohol use disorder. Let's go over these in a bit more depth. Physiological dependence relates to whether there is evidence of tolerance, that is, needing more and more of the substance to get the same results, or withdrawal, evidence of the classic withdrawal profile for the substance. Drinking causing trouble is another aspect of a diagnosis for alcohol use disorders, and that would be trouble in one's social life, physical ill effects of drinking, and negative impact on mental health. The other theme implicated in the 11 criteria have to do with this idea that drinking interferes with other aspects of life. And for this, I want to refer to this illustration of a pie chart that you see on the slide. The idea is that at some stage, the drinking will take up a small slice of a person's overall life, and still they'll be sleeping, they'll be working productively, spending time with family, doing hobbies that they enjoy. But what happens over time as the illness progresses is the slice of the pie gets wider and wider. The slice of the pie devoted to drinking, recovering from its effects, and planning to drink again gets wider and wider, and it squeezes out all those other areas. So all the other areas get less and less priority in a person's life as drinking kind of starts to spread and take over the pie chart. And finally, evidence of loss of control, that a person will drink more than they intended and they'll have trouble cutting down or stopping. And all of these together are themes that suggest that a diagnosis of an alcohol use disorder is present. In our continued discussion of what is addiction, I like to organize these thoughts around the idea that addiction is really confusing and bewildering, and there's a number of reasons why I feel this is the case. First, addiction is like other conditions that we're more familiar with, but it's not exactly like those other conditions. So we have a hard time really understanding addiction because it's unique. The other thing that makes addiction very confusing for individuals and families is the onset of addiction can be gradual. In its earlier stages, the problems can be intermittent rather than consistent. So the person's problem with addiction can be really bad, and there could be a big crisis, and then it can seem to get a little bit better. And then it gets really bad again. Another incident takes place, it gets bad again, and then it gets a little better, and then it gets then something bad happens again related to addiction. And this onset, this gradual and intermittent onset, makes people feel really confused about whether there's a problem there or not. And meanwhile, the problem is getting worse and worse, and almost imperceptibly because of this gradual onset. Another reason addiction is confusing and bewildering is the amount of shame and stigma associated with having this medical condition, far more than having other medical conditions like diabetes or high blood pressure. Addiction carries a higher stigma. And aspects of addiction are controversial, such as ideas about abstinence, ideas about Alcoholics Anonymous. Some of these aspects of addiction and recovery are controversial with strong feelings, and that adds to the confusion and lack of clarity. So we're going to go into each of these areas in a little more depth to help dispel misconceptions. So one is addiction is like nothing else. Addiction is like diabetes, hypertension, or asthma in that it is a chronic health condition requiring continuing care over a lifetime. A literature review demonstrated that these illnesses, all 4 of these illnesses, have similar rates of heritability, treatment compliance, relapse, and issues of personal responsibility. But somehow, if the question is addiction, we tend to be harder on people with that medical problem than people with these other medical problems. When individuals relapse after treatment in diabetes, hypertension, or asthma, it is attributed to treatment success. So if they stop treatment and then relapse, people tend to conclude, well, that's because the treatment was working. But with addiction, when they stop treatment, conclude treatment, and then relapse, people call that a treatment failure. I think that's a pretty interesting paradox. Addiction is like mental illness in that it is a brain disease and it is contained with the DSM. And it is like an allergy, but only to a point. Think of how we treat people with allergies versus how we treat people who tell us that they don't drink. Very often, people who don't drink anymore get a lot of pushback socially. We ask them, really, you can never drink ever? Can't you ever have one sip? Not even on New Year's Eve? What if you're at a wedding? Or what if it's your wedding? Can't you even have one glass of champagne? Or it's been such a long while since you drank. Wouldn't it be okay for you to have one now? We tend to push back and challenge someone who says, I don't drink anymore. But how do we react if someone tells us they have a peanut allergy? We don't say, really? You can never have a peanut? Can't you have just a little piece of peanut? Not even a peanut on New Year's Eve? Not even a peanut at a wedding? It's been a while since you've had a peanut. Wouldn't you be okay to have one now? I mean, when people tell us they have a peanut allergy, we respect that as a matter of life and death. We don't push back. We don't challenge it. We respect it, and we give it a lot of room, but somehow not for addictive behaviors. This is a slide I like to show my students, and I thought it would be helpful to include in this webinar as well. It talks about the progression of the development of an alcohol use disorder, and it harkens back to something I said earlier, that the progression is gradual. First, there would be maybe a single or a first incident that's negative that relates to alcohol. And then life goes on. The arrow represents time over a person's lifespan. And then over time, someone may have a second alcohol incident. Something else problematic happens, maybe an accident or something embarrassing or social consequences. So far, there are two bad things that happened. But maybe the person or the family isn't really adding this up yet. They don't really understand this to be something that's part of a larger, more chronic problem. And maybe it won't be at this stage. Perhaps there's then another incident. Some time passes and yet another incident takes place. And over time, if this is going to become an alcohol use disorder, eventually the person will meet at least one of the 11 symptoms in the DSM-5. And then over time, if this is going to progress and get worse and worse, which is the trajectory of addiction, they'll ultimately meet 2 criteria. And meeting 2 criteria of the 11 summarized just earlier means that you start to meet criteria for an alcohol use disorder, but the DSM calls it mild. But I have to emphasize that even a mild substance use disorder is still extremely debilitating to the individual and to their family. And I don't think the family members would say, this problem is only mild. The family would say, this is a very serious, extremely disruptive, and upsetting problem. A person may progress to the point where they meet criteria for 4 to 5 symptoms, and the DSM would call that moderate. And a person may progress to having 6 or more symptoms, and that would be considered a severe substance use disorder. Now, it's interesting to point out, again, that this onset can be gradual, that a person can even meet criteria for a substance use disorder and then be assessed a year later, and they don't meet the criteria anymore, but they're not abstinent, and then they will meet the criteria again, and then they won't. Depends on when they're assessed and their nature of their relationship with the substance over time, and that can vary and be intermittent. The other thing that's interesting about this to me is that if someone is able to stop drinking earlier on in the progression, it's going to be easier for them to stop, and it's going to be easier for them to stay stopped. And if they progress to the point of severity, it's going to be harder for them to stop, and then they're going to be more prone to relapse. There are many who say that addiction is a chronic relapsing disorder, but then there have been those who say that's only true for those at the more severe end of the spectrum. The other thing that's interesting about this is that there's a definitive cut point between when a person does not meet criteria and when they do meet criteria. So even though the progression is over a continuum and it's gradual, there is that point that scholars, scientists, and psychiatrists have said, well, here's where we draw the line between someone who does not meet criteria and then someone who does meet criteria, we can diagnose them with addiction. And that line is meeting 2 of the 11 symptoms. There's much shame and stigma that surrounds addiction. People, when they write on a cause of death or in memorial services, people, for some reason, they're more likely to say it was depression or more likely to say it was suicide than to say it was addiction. Depression and suicide seem to carry less stigma. I heard about a famous author who died because of a perforation in their intestine. But why did they really die? Because they were alcoholic and they drank a cocktail with a toothpick in it, and the toothpick perforated their intestine. So the cause of death would be perforation of the intestine and an infection, but not alcoholism, which really led the person to swallow the toothpick. There's still this pervasive sense that this is a sin or a moral failing. And there's stigma for having active addiction, for being in recovery from an active addiction, and from being a non-drinker. In some circles, there is stigma. So in a fascinating research study that I found, they looked at students in college who don't drink. So in this qualitative study, the authors surveyed students at a college campus that was known for partying. They surveyed students who were non-drinkers, and they studied students' subjective perceptions of non-drinking as deviant. So this was a medium-sized state university in the Midwest with 20,000 enrollment. And they did a qualitative study, and what they found is that the students who didn't drink felt a lot of stigma, and in this particular quote I'm going to read you, the person who was a non-drinker actually joined along with students who were drinkers to actually stigmatize and bully non-drinking students. And here's the quote from the study. We'd gather up all the red cups we could find with leftover booze in them, consolidate them into a few cups, and throw them in the faces of our targets. And the targets were students who were non-drinking and coming out of non-drinking social events on campus. Now that I look back on it, I was joining in with bullies just to protect my reputation. I tried to pass myself off as one of them. Those guys had no idea I did not drink. I fooled them all right, but inside after the fact, I'd sometimes feel sick to my stomach that I was really one of those very kids that we were harassing. So in this case, non-drinkers are facing a stigma. Another reason that addiction is bewildering and baffling is that there's much about it that's really odd and inexplicable. In the state of Minnesota, for example, residential addiction treatment can range from $200 a month to $1,065 a day in cost. Treatment for regular folks has a 40 to 60% success rate, while treatment for physicians has a 78% success rate. So what do we make of these kinds of disparities? Well, it's partly that for physicians and nurses and other healthcare providers, in order for them to get their license back, they have to be in a program that's 5 years in duration, and they have regular checkups and accountability throughout that time, and they have to stay in recovery groups all that time in order to get their license back. So that motivates them, and the chronicity. Addiction is really a chronic illness, but mostly we treat it with acute intervention, like 2 weeks of treatment or 1 month of treatment, and the person's supposed to go off and be well. But the programs for physicians are more in keeping with this idea of chronicity. They last for 5 years, there's accountability over a long period of time, and that is something that scholars believe account for the greater success rates. The other thing that makes addiction bewildering is that there's controversy around addiction. There's much we agree on. Addiction is a costly social problem. Individuals with addictions and their families suffer greatly. Many achieve stable long-term recovery. But there's much we passionately disagree about. People disagree about abstinence or moderation. There's this phenomenon of natural recovery where someone can stop the addictive behavior without treatment. And mostly those are people in the earlier stage. You remember the continuum slide? Those are people in earlier stages of the problem, of the severity of the problem. And they are also people who don't have a co-occurring mental illness. But those are people who can stop on their own without treatment. But still, that causes some mystery. People feel passionately about Alcoholics Anonymous, its use of spirituality and spiritual awakenings, its mention of prayer and God, and sometimes it is criticized in the public eye, despite the fact that it has helped many, many people get and stay sober, and also Narcotics Anonymous, the same thing. And then there's lots of tension around the idea of abstinence versus harm reduction. So people passionately debate these issues. They feel strongly about them. They can be at polar opposites, and that causes confusion and lack of clarity. We'll transition now to some content about addiction and child welfare.
Now that we have a better sense of what addiction looks like for folks, we want to talk a bit about what the history is and how to understand substance abuse in the child welfare system. So research and practice in this area have for a long time indicated that parental substance abuse puts families at risk for child maltreatment and subsequent child welfare involvement. The discussion about substance abuse and child welfare really began in the early 90s. Prior to that, there was very little research done, and the bit of data that was out there was a study from the late 80s that indicated about a quarter of the people they had studied who were in child welfare with substantiated CPS reports had parental use of alcohol and other drugs. So that quarter of people really concerned folks in the child welfare circles and began this larger discussion. So in 1990, the Child Welfare League of America convened the North American Commission on Chemical Dependency and Child Welfare. They were charged with assessing the impact of alcohol and other drugs on child welfare policy, practice, and research, and to sort of just get a sense of what was out there, what the extent of the problem was, and what should be done about it. They surveyed the field in a few ways across the country and found that anywhere from a quarter to a third of public child welfare cases were affected by alcohol or other drugs, and that those numbers were significantly higher in voluntary child welfare agencies. So those who were in the public child welfare system were affected at a rate of about a quarter to a third, and those in the larger voluntary system in child welfare were closer to 60%. They also found that children and adolescents who were involved in the child welfare system also used alcohol and other drugs at a rate of somewhere between 11 and 21% of the cases, depending on the type of agency and part of the country they were in. So they found that this was also a significant problem for young people in the child welfare system. So this group of folks called for a large amount of continued research, action, staff training, improved screening, and treatment and referral services, both for the adults in the system as well as children. Over the past 25 years, since that Child Welfare League of America work, we've seen a significant increase in efforts to understand and meet these needs. There have been over 300 published articles on substance abuse and child welfare, and many innovative prevention and treatment approaches have been tested. There's also been a significant increase in policies related to substance abuse and child welfare, both at the state and federal levels. However, researchers are also contending, and folks in child welfare, that more research in this area needs to be done. We still have a long way to go to really understand the extent and the correlates to substance abuse and child welfare, as well as what prevention and treatment works. And we'll be talking a bit more about this.
So the next segment of this module continues with this idea of what is addiction by a focus on the brain science of addiction. Addiction is known as a brain disease, it's known as a mental illness. Well, what does that all really mean? And how can we kind of get a grip on what's happening in the brain, the changes in the brain? They call them microadaptations that happen as a result of chronic substance use. And the way that those microadaptations perpetuate and intensify the nature of addiction. With ongoing substance use, changes in the brain occur. Changes to the brain's structure and to the brain's function. And these changes are called neuroadaptations. The changes in the brain are the result of substance use and set the person up to accelerate further substance use. Addiction is a cycle with 3 stages that also map to 3 major regions of the brain. The first stage is the binge intoxication stage, when the person is actively using the substance and feeling the effects of the substance. The second stage is withdrawal, which is accompanied by negative affect, and for some substances, physical illness. And then the third stage is preoccupation with using and anticipation of using again. And these 3 phases cycle round and round, actively being high, under the influence, in a state of withdrawal and illness, post-use, and then planning to use again. And these 3 map to brain regions. The binge intoxication stage is associated with the basal ganglia in the brain, which is responsible for reward, pleasure, motivation, and habit formation. The withdrawal negative affect is associated with the extended amygdala, and that's associated with our fight or flight response, the way we react to stress or threats in the environment, the way we react to negative mood, anxiety, and irritability. And the preoccupation anticipation phase is associated with the prefrontal cortex and has to do with that part of the brain's ability to do or not do a certain behavior, and its association with control of using or not using substances. There's some core terms that we need to know well to understand this addiction cycle. One of the terms is impulsivity, and that's acting without thinking it through. And that might be implicated when someone first starts to use a substance. The other idea, I'm going to skip down to the bottom of the slide, the other related idea is compulsivity, and that's an irresistible urge to use the substance again or to enact the behavior again. And that would set in at a later phase of addiction. So impulsivity at an earlier stage and compulsivity at a later stage. An important concept is the concept of reinforcement. Now, I know this is review for people, but reinforcement always feels good and is something that would be motivating. So positive reinforcement is when something good is added. So feeling euphoric or social approval for using substances, those would be positively reinforcing for continuation of substance use. Things that are negatively reinforcing would also encourage continued substance use. When something is negatively reinforcing, what happens there is that something undesirable is removed. So if someone uses the substance, then their irritability goes away, their anxiety goes down, they don't feel stress anymore, they feel emotionally numb. And for some, the sense of social isolation goes away because they're joining in with others who are also using the substance. So motivation for continuing substance use has to do with positive and negative reinforcers. Good things that are added and bad things that are taken away by use of the substance. And this helps us understand the addiction cycle. And scholars also make the very important point that at the beginning of a pattern of use of a substance, it's more strongly driven by positive reinforcement, that the drug use or the alcohol use feels good. But over a period of time and the progression of the illness, it's motivated more by negative reinforcement, by the fact that drinking or using drugs makes someone feel better, takes away a feeling of illness and makes them feel normal. So again, a look at the addiction cycle now with those terms in mind, that it is a cycle with 3 stages: the binge intoxication stage, the withdrawal negative affect stage, and the preoccupation anticipation phase. In the binge intoxication stage, is where we see the positive reinforcement going on for drugs, and not only drugs and alcohol, but the stimuli that are present when the person is using drugs and alcohol. The people, the locations, the things they use, when other things that they use, other objects that they use when they are using. And those other things, the stimuli, become very strongly associated with the feeling of high, which is when someone is in recovery and they're exposed to those stimuli, as people say, people, places, and things, it can cause neurochemical reactions that make it very hard for the person not to resume substance use. This part of the brain is responsible for learning and habit formation. The next phase, withdrawal and negative affect. This is where we have the region of negative reinforcement, where the person feels emotionally bad and physically ill, and if they use the substances, then they will get relief from those conditions. And again, as we mentioned before, the preoccupation and anticipation phase, the brain is in charge there of control of whether to use or not use. So these neuroadaptations in the brain caused by long-term use make some modifications in these brain regions that only accelerate further use. So in the basal ganglia, the brain becomes less sensitive to pleasure, which means you need more of the substance to get the same pleasurable effect. And even other things in life that cause pleasure, like food or sex, the person doesn't feel them as pleasurable anymore. And that drives an escalation in substance use in order to try to get to that feeling of euphoria or that feeling of pleasure when the brain is starting to dampen down on its ability to experience pleasure as a result of chronic use. And then in the extended amygdala, this part of the brain becomes more reactive to stress and produces many more stress hormones. So the person, because of extended use of substances, is feeling more stress, is feeling more negative affect, and that also drives an escalation in substance use because they're just really feeling very desperate for some relief. And the prefrontal cortex's role in all of this is a lot of diminished ability to say no and to stop. So that part of the brain is compromised in its ability to stop. And basically, a lot of what happens in this region is rationalization for the addictive behavior. So neuroadaptations cause an overwhelming drive for substance seeking that can be unrelenting. I really kind of like the way this is phrased because it really emphasizes that the urges are almost impossible to resist. Now, I had a student who wrote in one of her papers that there is an intense need to satisfy the fury. And I thought that this was really a very poetic and a very, really accurate way of describing the way someone who is addicted feels about the urge, the unrelenting urge to use. Fury in the dictionary is defined as a ferocious feeling, a wild feeling, an intense feeling, something that you can't concentrate on anything else. It's roaring away. And those brain adaptations are just driving things to get worse and driving the person to continued and intensified use. So why is it so hard to stop? Well, let's think about it. The affected parts of the brain that we've just been talking about deal with learning, memory, habit formation, pleasure, fight or flight, the avoidance of danger. And these are all parts of human psychology that are implicated in survival, that help us survive and avoid threats and move toward things that will enhance our survival. So our sense of pleasure in eating helps us to maintain our own lives. And so what happens is this idea that addiction hijacks the brain. It uses existing brain pathways and structures that are deeply implicated in human survival and survival of the species. So it feels to the person like substance use is necessary for survival, that they must use. It becomes a drive as powerful as eating or sex or drinking when you're thirsty or sleep. And the drive to use substances becomes equal in force to the drive to survive. So it becomes a feeling that a person can't even really explain it, but they just must use, and it's because the brain has been hijacked to, and the person's really been fooled that they must use. It feels like a life or death situation. I want to talk for a minute about an assignment that I use for my addiction class. I ask students to undertake a week of abstinence, and they have to choose a behavior like coffee or social media or sugar or eating out in restaurants, something that they do habitually that they feel that's not that maybe that healthy for them, that they should cut down. They're asked to abstain for 1 week, and they're not allowed to tell other people that they're abstaining because of a course assignment. And what my students report as a result of this assignment is they report that they feel shame when they relapse. So this is a made-up assignment. It's 1 week in duration, and it's for a class, and yet they feel shame when they cannot stay abstinent. And it really gives them the feeling of understanding the shame that people with addictions feel when they try to change. My students report that they get criticized, teased, and scolded and reprimanded by their family and friends. So if they turn down dessert, or if they tell friends that they're off social media, that their family and friends can scold and reprimand them for that and push back and challenge them. They also report social isolation because they turn down social events in order to avoid being faced with sugar or alcohol or social media. And they come away from the assignment with increased insight into addiction. In addition, students in the assignment report realizing the importance of planning ahead. One student wrote about going to a barbecue, and the only thing to drink was soda, and she was trying to stop drinking soda as her behavior, and there was nothing else to drink, so she was kind of stuck. They also realized the importance of social support, letting others know that they're going to be making a change, and then finding those in the social environment who are going to be supportive of that change rather than challenging it. And they also report realizing how very difficult it is to change a behavior. I had 2 students say they stopped Facebook for their behavior, and they said that they opened their phone and they pushed their finger down on the spot where the Facebook app used to be. That was how strong the compulsion was to log into Facebook. So they had taken the app off the phone as a way to help support their week of abstinence, but 2 different students said that they found themselves pushing on that spot like the ghost of where the app used to be. And this helped them realize how very desperately hard it is to stop a behavior.
All right, so to switch gears back to child welfare once again, we want to talk a bit about how many child welfare families are affected and how they're affected. So the prevalence of substance abuse in child welfare, statistics in this area vary widely. So while the field of child welfare has made great strides to understand the issues related to substance abuse and child welfare, there still remains large gaps in this literature. And one of these gaps is in statistics to help us understand the prevalence of the problem. Available data varies widely, and there's no standardized national data collection on this topic at this point. Now, in 1999, it was estimated that between 1/3 and 2/3 of child maltreatment cases were affected to some degree by substance abuse. Subsequent reports since then have indicated that this range varies widely from study to study, and it often depends upon many factors such as the geographic area of the study, differing definitions of substance abuse, and the type of child welfare involvement. The most recent estimates find that parental substance abuse is a factor in approximately 15% of child welfare investigations and approximately 25% of substantiated cases. We also found more recently that children placed in out-of-home care may be even more highly affected by alcohol and other drug abuse, as 61% of infants and 41% of older children in out-of-home care are from families who are affected by substance abuse. So what is the impact of substance abuse on child welfare-involved families? Many of you, because you're in the field, could probably write this section, so I'm just going to summarize a few of the areas that the research tells us. The effects on children and families and child welfare start with the fact that these families are more likely to be reported to child welfare. So where substance abuse is present, those folks are more likely to be reported to child welfare in the first place. They're also, as we were just talking about, then more likely to be placed in out-of-home care and to stay in out-of-home care longer. We also know that many of those who are affected by substance abuse are also affected by co-occurring issues such as mental illness, post-traumatic stress disorder, social isolation, poverty, unstable housing, and domestic violence. And this makes it very difficult to pinpoint the specific roles of substance abuse and child maltreatment and makes some of the research a bit tricky to sift through. There are also significant effects of substance abuse on the child welfare system as a whole. It increases the number of children and families who are requiring child welfare services. It's been found in research that substance abuse compounds problems that are already in the system, such as lack of personnel and foster home shortages. And it also complicates and lengthens service delivery and takes more out of the systems that are in play. It can also frustrate efforts at family preservation and reunification, and taxes the limited treatment resources that are available in the community. And what we find overarching, and part of the reason for doing this webinar, is that many child welfare workers are not trained to identify and treat substance abuse problems.
And the last portion of our module here is a discussion of what is recovery. Here it's relevant to think of these terms that we usually associate with the criminal justice system, the idea of cease and desist. And it's very important to understand with recovery that it's not only stopping, but it's staying stopped. And the staying stopped phase of recovery is a very active phase. I'm thinking of the Mark Twain quote, "It's easy to quit smoking. I've done it hundreds of times." Some people think that quitting an addiction is like graduating high school. In other words, when you think of graduating high school, you remember back to when you graduated high school. It was long ago. You remember a couple of hours spent, maybe your cap and gown, but then it's something you did a long time ago that you really don't do anymore, and it's something way in the past. But some people feel that stopping an addictive behavior is like graduating high school. It's something someone did long in the past. It's long in the history of their lives, and it's over and done with. But really, stopping an addictive behavior is more like going to the gym. It's something that's ongoing and is a very active and present part of the person's life for all the days of the rest of their lives, for many. There have been some scholarly definitions of recovery. SAMHSA has said that recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential in 4 areas: health, home, purpose, and community. The Betty Ford Institute convened a consensus panel of experts who came up with this definition of recovery. It is a voluntarily maintained lifestyle comprised of sobriety, personal health, and citizenship. What these 2 definitions have in common is an emphasis on health and abstinence, and an emphasis on community and citizenship, and an emphasis on increased meaning and purpose in life. And they both definitions say it's not just abstinence, it's abstinence plus other changes and other dimensions. Currently, we are in the midst of one of the richest historical moments in recovery from addiction. There's currently so many new dimensions and aspects of recovery support services, more now than ever in the history of addictive behavior. There's something called recovery coaching, when people are trained to be coaches in helping people with the chronicity of addiction over time. There's recovery housing, sober living houses. There are recovery community centers. There are 2 in the state of Minnesota. These are brick and mortar buildings which provide all kinds of services to people in recovery so that services don't stop just when the person's in treatment. Services continue during the phase of recovery. Recovery management is a philosophy of treatment where people are followed up, like those physicians we mentioned some slides ago, followed up regularly over a period of years after treatment. And there are recovery high schools where the children attending these schools are in recovery, and dorms on college campuses that support individuals in college who are in recovery. These are new phenomena over the past 20 years. Of course, there are also mutual aid groups which support recovery, like Alcoholics Anonymous, Narcotics Anonymous, Al-Anon for family and friends. Smart Recovery is also a support group of people in recovery, but it does not have the spiritual component of 12-step programs. Women for Sobriety is a special group program for people maintaining abstinence, focusing especially on women. Currently, we're in the midst of a major advance in the field of addiction recovery, and that is the addiction recovery movement. This is the idea that people in recovery are convening and becoming active politically in policies that affect addiction and recovery. It's putting a face to recovery. All of us know what addiction looks like. We know people who are addicted either from media images or people we know personally or people we see on the street. And we know what that looks like. But when people enter recovery, they become invisible, and people don't know what that looks like, and that fuels stigma. So the addiction recovery movement supports these community recovery resources and work in political advocacy. There have been some media campaigns that help to put a face to the experience of recovery. And there's been a new film that you can find online called The Anonymous People, which talks about this shift where people in recovery are coming out and saying that they're in recovery so that society can have a face and know what recovery looks like instead of recovery being invisible. And then the only thing people know about addiction is active addiction. So we're concluding our module, and what we're going to do in the next several slides is we're going to talk about what our main takeaways are from all that we've presented so far. So in the slides I've presented you with, I want to conclude by saying addiction is perplexing for many reasons, and that's partly because it's similar to, but not quite like, other illnesses or conditions, and the nature of shame and stigma that attends addiction even now that we know that it is a medical condition. Addiction is not a moral failing, long established as a medical condition, as a brain disease. I want to leave you with the idea that recovery is richer than ever. The resources for recovery, the advocacy behind recovery, we're in a very, very rich period for the idea of recovery, and that should help reduce stigma, and it should help other people find recovery. I hope that what I've presented here in this module, insight into the brain science that drives addiction, insight into the criteria for alcohol use disorder, the way the disorder has a gradual onset that can be confusing to individuals and families. I hope that this leaves viewers with this idea of empathy for people with addictions and their families. I want to talk about a resource that I recommend that I've drawn from for this PowerPoint. The Surgeon General of the United States has put out a report on facing addiction in America. It's the first such report. It just came out, and you can get a copy for free, or you can Google this and you can download all of it. You can download it chapter by chapter, or you can download the whole thing. And again, if you want a hard copy, the government will mail you one for free. And it consolidates and summarizes the most recent science of addiction, treatment, recovery, the brain science, and many of the points that we raised here. So this is an extremely valuable and luckily accessible and free of charge resource that we can all avail ourselves of. This idea of empathy for people with addictions, I want to build on that just a little bit. Just earlier this summer, I heard a lecture by John Renner, a psychiatrist. And John Renner is the Associate Chief of Psychiatry at the Boston VA. He's a consultant at the Department of Psychiatry, Mass General Hospital. He's a professor of psychiatry at Boston University School of Medicine, and he's the president of the American Academy of Addiction Psychiatry. And I was very struck and moved by his lecture that I heard, and I want to repeat some of the takeaway points that I got from his lecture, because I feel that they support and undergird many of the points that we've made here in this module. And so what I'm going to be reporting to you are from my notes from hearing his lecture. So this is what I heard him say. One, he said, "How can you be a psychiatrist and not an expert in addiction?" I thought this was terrific. He furthered that by saying, "How can you be a social worker and not an expert in addiction? When you think of how pervasive addiction is, how it affects all avenues of mental health and social work, how it affects child welfare, criminal justice, everything that social workers concern themselves with, we really all have to be experts in addiction, not just people who specialize in that area." I completely agreed with him, and I felt he understood addiction. He said people with addictions have had their self-esteem destroyed. They feel defeated. Don't give up on them. It can be very easy to become impatient and angry and frightened by this baffling and bewildering behavior of active addiction. But he made the point that if we can somehow let people know that we have faith in them, that we believe we can change, that we feel sure they can do it, and that we don't feel a sense of social stigma, a sense of disgust. If we can have that tone, it can really make a difference. He gave this advice, which again I thought was very powerful. When meeting a client with addiction, assume the person is depressed. Assume this person's self-esteem is zero, and be very gentle with them. And I thought this was useful because the way that we naturally respond to active addictive behavior, we can very easily respond with frustration and irritability. But what he is saying is try to employ exactly the opposite. Try to employ gentleness and patience. And that tone, them hearing that tone from us, could make a difference in how they respond to our suggestions.
I want to share a few takeaways, specifically drawing this information back to the field of child welfare. So we know from this bit of information in our slides today that the field of child welfare has long been concerned about substance abuse and its effect on families. That over the past 25 years, we've really seen an uptick in research, policy, and practice changes to help meet these families' needs. And we also know that there's still so much to do to meet the needs of these families. And many of you in practice have told me in classes and in supervision and out in the field that this work with families who are addicted is really hard work, and it's complicated, and it's hard to understand how the system can better meet their needs. One particular additional resource that I think might be helpful for you is on the bibliography. There's a report from the Child Welfare Information Gateway from 2014, and it's a bulletin for professionals about parental substance abuse and the child welfare system. So if you'd like to do a bit more reading and get a little more information about what's been going on and more statistics in this area, this would be a great report for you to read more thoroughly.
We want to thank you for participating in this webinar today and for all that you've learned. And I think in the moments that we have remaining, I can make just a few suggestions about additional projects you can engage in, things you can read, and activities you can become involved in that can help expand your understanding of addiction and better serve your clients. I mentioned the assignment to students of 1 week of abstinence. You could try that if you like and see and get some of these insights for yourself of what my students have experienced. Another really compelling assignment is I ask students to attend an open meeting of Alcoholics Anonymous or Narcotics Anonymous. And students are usually quite anxious about the idea of doing that. But these open meetings are intentionally established by these organizations for the purpose of letting the community in and observe a meeting and understand what goes on in meetings firsthand. And they're established for that purpose, and they would welcome social workers to come in and learn so that they can then help other people more effectively. So what you would do to find such a meeting is you would search Alcoholics Anonymous and then the name of the town that you would like to go to the meeting in. And one of the first search results will lead you to a meeting list. And there should be a key that indicates an O for an open meeting. And that would be one where you're welcome to attend as a visitor from the community. I ask my students when they attend such meetings to arrive early and to just double check with the person leading the meeting that day. Let them know they're a student, let them know they're there to learn more about addiction and learn more about 12-step programs. And just to double check, is this an open meeting and is it okay for me to stay? And the person can then confirm that it is an open meeting. And that helps my students feel more at ease. And students report that they're so touched by what is said at the meetings, that they are warmly welcomed, and that they see the bond that people have with one another. And they really learn quite a lot and can be very personally touched and moved by the experience. So they come away feeling that despite feeling anxious about doing it, they come away with an extremely rich and enhanced understanding of addiction and recovery. Some even say it's the most memorable assignment of their whole MSW program. So we leave you with a description of the bibliography that both references the details of what we describe in the webinar, as well as some additional readings. And Karen had mentioned the one report that she felt would be useful. That's the one that we see, the third one listed here, Parental Substance Use and the Child Welfare System. The DuPont study talks about something I had mentioned earlier, how are addicted physicians treated, and that could be of interest if you'd like to read more about those comments. The study that I mentioned about the students who are sober on heavy drinking college campuses, that's the Herman, Kenny, and Kenny study, second from the bottom. The last study, the Lohman et al. Study at the bottom of this slide, is a study of researchers' understanding of the reasons that people relapse. And the study, the McClellan study, the second bullet point, is the one that talked about how drug dependence is very similar to diabetes and other chronic illnesses. So if you wanted to read more about that, that would be that resource for you. There were a few changes from the DSM-4 to the DSM-5 in terms of alcohol use disorders, and that's summarized in the third bullet, which is something you can just find on a Google search. In DSM-4, they had the idea of substance abuse and substance dependence, and that idea goes away in DSM-5 because rather than having these sort of definitive stages, they understand it to be one single continuum. Another really interesting addition in DSM-5 is the addition of gambling disorders as an addictive disorder, and this is the first time that a behavioral addiction is considered in the DSM to be an addiction, with other behavioral disorders under consideration for future versions of the DSM. And then finally, the second from the bottom is the Surgeon General's report that I had mentioned, and we hope that you read through some of these other items and find them as useful as we have. Once again, thank you for tuning in, and we've appreciated your attention.